Hi, I'm Dr. Stephanie Eken. I'm the Regional Medical Director for Rogers Behavioral Health. I'm a child psychiatrist and a pediatrician.
And I'm Dr. Brad Riemann. I'm the Chief Clinical Officer of Rogers. I'm a clinical psychologist by trade, and we want to welcome you to our fireside chat to talk about telehealth and how Rogers has been utilizing it historically, but also during the coronavirus pandemic. We're going to be going over a little bit about who Rogers is. We're going to be talking about, again, our historical use of tele, all of the changes that we needed to make here recently to serve our patients through the pandemic, and then just kind of have a little bit of a free-flowing conversation. We're going to be able to take your questions via chat during this time as well, so we look forward to that portion. But I want to first start off by just giving you a little bit of introduction about Rogers. So Rogers is a freestanding not-for-profit behavioral healthcare system founded in 1907 in southeastern Wisconsin. We have grown tremendously over the last 10 years or so. We now have 18 sites in 8 different states. We have 2,500 staff members, and we admit over 22,000 patients a year. We don't offer the traditional outpatient level of care. Our lowest level of service is IOP, defined as 3 hours a day. We also have PHP, 6 hours a day, residential, and then inpatient. And our services that we offer do vary by location. The residential and inpatient is in Wisconsin only, where we're headquartered. And then we have our IOP, PHP outpatient clinics in the other locations and states that I mentioned. So, Dr. Eken, I'd like you to start off by just telling us a little bit about the history of telehealth services and how we've utilized it psychiatrically over the years at Rogers.
Yeah, so telehealth isn't new for us. We've been using it for several years now. So we started out because we didn't have enough psychiatrists at a particular clinic in Kenosha, Wisconsin, for PHP and IOP. So we were able to broaden our services whenever we offered telepsychiatry there. But we've been using it more robustly as we've opened up our sites outside of Wisconsin. So our first site was in Tampa in 2014. And quickly after that, we opened some other sites, Nashville, Chicago, and moved on from there. But we started to see that, we had maybe 1 or 2 providers, meaning psychiatrists or nurse practitioner at a site. And if one of them's on vacation or has a life event or whatnot, we want to continue to be dedicated to, admitting patients when they need us. That's been a big, tenet of ours. And then also to provide specialty care of what they need as well. So it's allowed us to provide addiction services, child and adolescent, psychiatry services when maybe we couldn't have that particular specialty hired in person at that location. So we have been getting licensed in multiple states since then and using it to cross-cover and or start specialty programs in those sites.
Yeah. So clearly, telehealth is not new to Rogers, and as you were describing, we were using it primarily from a psychiatry standpoint. Tell us a little bit about, however, the expansion of that here over the last few months.
Yes, well, we've all been in this coronavirus pandemic, which has led to a lot of changes for us in how we practice. And so it quickly became evident that we needed to be more robust in what we were offering via the telehealth platform. So at that point in time, our patients were always in our clinic when we were providing any kind of telemedicine services before, right? So the doctor might not is in a different clinic or potentially at home, but the patient was always in the clinic. And with the coronavirus pandemic, we were still an essential service, but yet people were really concerned about coming in and being exposed, and rightfully so. We operate in a lot of cities where there were increasing numbers. So we then developed this more robust platform with Rogers Connect Care. Dr. Riemann, he and I worked very closely together to provide training to our staff so then we could provide our PHP and IOP services through a complete telehealth platform. The patients could be at home. The staff could be at their own home too. I think that was really important from our CEO's perspective too. Pat Hammer, he continually talked about it's important for us to keep each other safe during that time too. So he was supportive of doing everything we could to, if we potentially could have our employees at home as well. So There were a lot of hoops, though, to consider as we were trying to put this, on a completely telehealth platform. One of them was just the regulatory standpoint, but quickly with the public health emergency that was announced with the coronavirus, it seemed to allow for a lot of the regulatory bodies then to to be able to loosen things so that telehealth was allowable, because in some of our states, it wasn't something that like where the patient could be at home. So from a federal and state level, we began to see some ability to provide that. And obviously we wanted to be in line with all regulatory bodies. I know CMS also was supportive. And I don't know, Dr. Riemann, if there are other regulatory bodies as well that we were considering.
Yeah, no, we were in communication with certainly many of them. And of course, one of the challenges, as you mentioned, was being in multiple states. We had to be on top of really what was happening in each of those areas, and not just where we had clinics, but whether we could accept patients from states that we didn't have clinics in and those kinds of things. So it was certainly quite the effort. And at this point, we're treating over 900 patients a day in IOP, PHP. And I think one of the, certainly the number of patients that we're seeing every day was challenging, but then also the fact that we were providing, IOP and PHP, so 3 hours a day or 6 hours a day. Tell me a little bit about, how you felt that went with the teams, with the staff. I mean, what kind of attitude did they have about that?
Well, I mean, I think we were really fortunate to have a staff that was, they had their own anxiety, of course, around the coronavirus pandemic, and they wanted to do everything they could to keep their families safe. And frankly, some of them had immunocompromised people at home too. So I think there was some impetus for their excitement from that standpoint personally, of course. But also, there was this growing excitement, honestly, as we began to do it because they saw some strengths of the telehealth platform. So we did a lot of trainings in the beginning. So we were able to, at that point, we were using Microsoft Teams, not as our telehealth platform. Interestingly, we had been using Polycom for telepsychiatry, but our, all of our very smart CTS people helped us quickly shift over to Microsoft Teams. It was a move that we had been considering for several months, and this was the thing that got it rolling. And so it was HIPAA compliant. They felt that it would also just be easy for staff to use. So we combined our efforts with them, obviously from the clinical side, the psychiatric side, everything coming together, doing all these trainings. You provided a lot of trainings. I did a lot of trainings for our psychiatrists. But our frontline staff, so we had this whole checklist that they had to go through and prep them and be prepared to work from home. And I think the strengths that they saw were seeing patients in their own environment. There were some real advantages to that. So they were very excited about that. But overall, I think our staff have been excited about this, but it was also complex in that they also had to figure out how to work from home with all the other factors going on with coronavirus. Kids maybe being at home, spouse maybe being at home, everybody on the Wi-Fi, all those things.
Yeah. So there certainly were technical challenges as well, and not only with our staff, but with our patients and making sure that they had the proper hardware, software, and internet access and all of those kinds of things.
Exactly.
And then obviously, we also took telehealth and tried, to apply it to the residential and inpatient setting. Obviously, the patients have to physically be here, so the patients themselves obviously weren't, remote. But we went with kind of this preservation model, where we had 50% of our staff in those programs working remotely. And remotely could have been from an office here on site, but not on the unit, or most of them were at home. But the idea here, Dr. Eken, of course, was just to try to preserve the staff. I mean, we did not know what the future held for us. We knew that we couldn't afford to have our teams become ill and not be able to provide service to these patients. So, again, half the staff were at home, and the other half on the units. and then they would flip-flop 1 week to the next, so they would kind of rotate in. It's worked remarkably well. I mean, there were certainly challenges, as you can imagine, one of which was getting enough technology on the units, because everybody needed Chromebooks and laptops and all of these kinds of things. Yeah. From a patient standpoint, even space was a challenge. You have to have that dedicated office for someone to be able to do a telehealth session, and so we were scrambling to really try to get creative with space, staffing, schedules, program schedules even had to be tweaked to kind of make this all work. But the good news is it really did accomplish its goal. We've been able to keep our staff safe. They've been able to continue to provide this much necessary service because clearly the demand for services has not reduced, right?
Right.
And whether it's in the outpatient world or more in residential or inpatient, the patients have still needed service. And in fact, frankly, I found that very inspiring.
Right.
That in you remember in the early days of the Corona scare, we still had patients coming in and saying, thank you so much for staying open. Right. They were coming into treatment. We kept it in person as long as we could safely. But I was really inspired by the patients and the fact that they valued the service they were receiving and wanted to continue to get better.
Right. Yeah. And I'm just curious, I know that you are genius when it comes to clinical outcomes, and clinical outcomes has been something that we've tracked historically at Rogers and has been important for us in how we, if we're going to change any kind of programming in what we do. And so I know your team worked hard as well to make sure that patients were still receiving, excellent care. So I'm curious about patient satisfaction and also clinical outcomes, what your team saw with that.
Yeah, those are great questions. And what I would say is that, we quickly put in a satisfaction survey. So all of our outcomes are automated. Okay. So patients, get into a program, they complete all of our questionnaires, and we added a satisfaction survey to those outcome measures, really, I think, within a few days of starting the telehealth service. We've had hundreds and hundreds and hundreds of patients now complete the satisfaction survey. Basically, there was a couple of important questions. One was rate on a scale of 0 to 10, how satisfied you were with the technology. We have been at 7 out of 10 really from the get-go. And I think that's pretty remarkable given the fact that we turned this thing around in about 5 or 6 days. Right. And so,
we didn't even talk about that timeline. It was very quick.
Yeah. And so they've been satisfied with the technology. And then the second question on that 0 to 10 scale is how satisfied are you with your service? And again, we've scored 7 out of 10 on that. As you mentioned, some patients have brought up in the survey advantages they feel that they've experienced from this, some of which is distance to the clinic, that this was actually not only more convenient, but actually allowed them to seek care. Because if we did not have tele, the distance to one of our outpatient clinics would have been too great. As you mentioned, people had kids at home, so they wouldn't have been able to come into treatment even if it was a couple of blocks down the street because they had kids at home and they had to watch them. So there were certainly advantages that our patients picked up, and even things like getting into, say, for example, the OCD world. People being able to do exposures at home and our staff being able to view them doing this exposure at home versus kind of in your mind's eye and kind of doing the best you can to imagine what that might look like. So there really were some advantages that way as well. From an outcomes perspective, the data kind of keeps rolling in. And what I can tell you is if you aggregate the data across all of our subspecialty programs, the data is very strong. It really seems to correspond with what we would normally find. The ends in each of our subspecialty groups, haven't gotten to the point where you can draw many conclusions. They look good, but again, if you aggregate it across all of our patients, The number one thing that we use to evaluate programs' effectiveness is effect size, and our effect sizes in aggregated seem to be this as strong as they normally would be. And I think one of the keys that has enabled us to engage patients for 3 hours a day, engage patients for 6 hours a day, is really kind of our standard treatment protocols.
Right.
And so that manualized treatment, kind of keeps them engaged. We can say, hey, turn to page 33 of your manual, and those types of things. And I think that's been a huge asset right now. And I think certainly one of the number one reasons why those outcomes have remained strong.
Yeah. This is probably a complicated question, but I know one of the major things that we track is quality of life for our patients.
Yep.
And, and we look at that data frequently, every other week for our entire system, I know. And we were thinking during the coronavirus pandemic that just in general, people's quality of life would be impacted, but we want our treatment to be helpful. But can you talk a little bit about like how our quality of life measures look like during that time?
Yeah, that's a great question. Obviously the necessary but forced isolation is really a breeding ground for stress and anxiety, and people have had so many concerns about loved ones in other parts of the country, maybe elderly parents or grandparents, financial stress, maybe you've lost your job or been laid off. And so there's just this tremendous amount of pressure. But one of the amazing things that we've seen is our patients are very resilient.
Yeah.
And despite all of these things going on, they've come in, they've worked hard, in virtually, worked hard. One of the things too to note is our attendance remote.
Gone up.
So it's actually gone up. Normally we're at about 90 to 91% attendance for IOP PHP. It's been about 94, 95. And not to say that they've had blinders on, but they've really been able to still focus in on taking care of themselves and their behavioral health needs. So we've seen the same, kind of the traditional increases in quality of life that we would normally see. And again, I think that's really inspiring. I think that, and the other half of that is the staff. I mean, I think we can be super proud of the teams and what they've continued to do. As you mentioned, other than some of our psychiatrists, people had never done any sort of telehealth kind of work before. There was a lot of fear of the unknown and stress and anxiety about doing that. And, they quickly kind of picked that up and really remarkably are providing really identical treatment to what they would be doing face to face, but just remotely.
Yeah.
I was just going to ask, Dr. Eken, in terms of, obviously you were more closely tied into the IOP PHP level of care. Yeah. Were there some patients that you had concerns about treating? Again, keep in mind that if it's an IOP or PHP patient, there's a certain level of severity and complexity by nature. Were there patients that you were concerned about treating there, and how did we handle that?
Yeah, so there are a few scenarios that we spent a lot of time considering, but also then individualizing their treatment then because certain things became treatment targets that maybe necessarily weren't outside of the virtual world. So I can give you a few examples. One is our eating disorder patient population. So body image is, typically a main component of some of their struggles and how they present. And so on Microsoft Teams, one of the things is you have a view of yourself the entire time and you can't turn that off. And so they were really struggling with seeing themselves on camera. Other people seeing themselves on camera, it felt different to them than being seen in person. They still do a lot of in person, they wear clothes maybe to manipulate those things, but on camera, it just felt different to them. So we, use exposure therapy to try to help with certain aspects of anxiety. And so we were able to use some exposures, and you could probably talk in much more detail about that, but we were able to make treatment targets for that. I think it was really interesting on the child and adolescent side, where we had been using family-based therapy, which is, an evidence-based treatment protocol for our child and adolescent eating disorder patients. And it was a real, this is a fairly new approach for us in the past year. And boy, all of a sudden we're in the deep end of the pool with that, where, okay, parents really are the ones that are feeding their children. We are not there providing meal support in the same way. So I think that actually was good for us in certain ways, because it really strengthened some of the theoretical piece that we had been working on. And it really helped us to empower those parents in a new way. So that was an interesting challenge. Our child and adolescent patients too, the younger side of the spectrum. So we treat all the way down to, 6 years of age in our partial hospitalization programs. And you can imagine being on video for 6 hours for a 6-year-old would be very challenging. Plus their parent, when we're in person, is highly involved in their treatment. And it was really uniquely challenging in that, right, if they're at home, then those parents had other children at home too that they don't normally have, because school wasn't happening or their baby, daycare wasn't happening. And so we had some challenges around our younger patients. Yeah. And then in general, this is not unique to Rogers, but all over the country, patients with addiction were struggling in really interesting ways with the coronavirus. So all over the country, there were increased, stats showing us that they were relapsing more, all those kind of things. And so I know for our patients in our dual diagnosis programs and our addiction programs that they were, they're right often in the environment where they maybe have used historically, or maybe now it's harder to get things. So with the whole coronavirus. So I know that was a population that struggled more. We got innovative though too, and started doing these mouth swabs to check for drug use, rather than trying to bring them in to do urine drug screens. So we really tried to do a lot of things to help make sure we were keeping them as safe while we were treating them virtually, and taking vital signs in new and unique ways that we hadn't. So if they had equipment or they had an Apple Watch or these different things, our nurses would get their vitals in those ways. So it's very interesting.
So these addiction patients would swab themselves and then show you the results on virtual, so that you would know.
It was 3 minutes of an oral swab, and then they could show you. It's what we traditionally know as a point of care cup that's usually done with a urine sample, but this is done with saliva. And so they could show us the results right there. The nurses could also take their vitals with equipment that they had there. We also did that with our eating disorder patients by taking their vitals. We had to get very creative with that because obviously for our really malnourished patients, we needed to know weights. And so we had to have someone assist to do blind weights.
Another piece of data that we got out of our survey results were that 50% of our IOP-PHP patients actually prefer telehealth. So it was kind of divided right down the middle, 50% for in-person, 50% prefer tele. Interestingly enough, age has nothing to do with it. So we looked at under 18 and over 18, and each age group was also divided perfectly equally, interestingly enough. So if 50% of our patients prefer this, and we've talked about advantages such as allowing people to get access to treatment that otherwise wouldn't have been close enough to a clinic, some of the advantages related to, being in home and seeing them do exposures or whatever it might be at home. What do you see the future of telehealth at Rogers being?
We get this question a lot. And I think there's some real advantages for our patients. I think, there are some potential barriers that may come back into place that will help us understand what we can do with this as well. I also just want to mention that I think people can ask us questions in the chat feature of this. So if people have questions, we're happy to take them at the end of this. But this is a complicated question on a lot of levels because regulatory, payers, all of that is going to play a role in how we do this. Things were really opened up for us. We were able to see patients in a lot of states in unique ways that we likely won't be able to if we go back to where we were, from a licensing standpoint, typically you're licensed where the patient is and where you're at. And obviously being licensed in, 50 states is complicated. Lots of educational credits, all those kind of things for all of our people to do those kind of things. But my hope is that we'll end up somewhere in the middle. I don't think we're going to be where we're at right with the coronavirus pandemic sort of things that open. I hope the payers will help support this as well, because I do think that there are groups of patients that will do better if we can have some either combination of in-person and virtual, or all virtual. We can serve more people. So my hope is that we could move forward with patients that we know them being at their home could be beneficial to them. Maybe they can't receive treatment otherwise, or their specific symptom presentation would suggest that them being at home and us helping them work through it would improve their outcomes. And I think, we saw some of that, as you mentioned, with some of our OCD, our patients with OCD, being in their home is critical. And some of them have, as part of their OCD presentation with hoarding, that was something that we really struggled with before to help them with, right? They'd have to bring stuff into the clinic. Can you imagine being able to do some of that for our patients in their home?
Yeah, that would be a huge, huge advantage.
Yeah.
And my hope is that we'll still be able to explore the use of this as well. You had mentioned, the all important things related to regulations, payer support, and then obviously the outcomes, right? I mean, we're gathering that, as I mentioned before. In aggregate, it looks very strong, but we want to, be able to see, well, maybe it does work for this population and this one very well, but maybe not so much on this one.
Right.
And, then of course the goal would be to how to improve that so that we can maybe help them as well. But, I think the access to care was huge. We've seen that being able to deliver treatment to people who otherwise would not have been able to get it. I think there's an enormous advantage, as you mentioned, in sprinkling in, this throughout a stay. So even if the vast majority of time is in person, I remember in graduate school when we would see OCD patients, we did a home visit with every patient, and it was enormously helpful. We could walk through room to room, and they could show us all of the different things that they had problems with. So developing their exposure hierarchy was so much easier. Of course, we were graduate students; nobody was paying us. We could kind of do whatever we wanted, right. but it was hugely advantage, and there was a huge advantage to it. And it kind of reminded me of some of the advantages we were able to pull. Like I said, even if we just sprinkled it, in there, and the patient's voice has to be heard. I mean, 50% prefer this, and we also probably, we could tap into subpopulations that you might have housebound agoraphobics who really need a high level of care, but just can't leave their house. And I could see where we might use initially to engage them in treatment, and as they make progress, we have them come in person into the clinic, when they're ready to do that. But I do think, you had mentioned, we have a work group here at Rogers kind of looking at what telehealth is going to look like in the future, and we did kind of, put this model together in a very brief period of time. It is doing what we needed it to do. But how do we make it more engaging in the long run, whether it's that 6-year-old child at home or whoever it might be? How do we enhance it? How do we fully take advantage of the technology that's available to us to make this a more satisfying experience? How do we get those satisfaction ratings from 7 to 9? Right. And I think that's going to be a challenge for all of us, all providers, and because I do think the genie is out of the bottle a little bit, and I think going back fully to the way we have done this would be a mistake for the very reasons we mentioned.
Right. Well, I just, as you were talking, I was thinking too about, it's so typical for us to see families uproot a parent and a child to come get treatment at one of our sites who don't live close to one of our, settings, because we provide some pretty specialty treatment with some really amazing outcomes. And think if we could provide that for them and they didn't have to separate their families for weeks and to, have to take on those extra costs, that would be incredible for those families as well. So there's, you can just start to think of all the possibilities. And like you said, if we have more time to spend on this too, we can make it even better than where we're at. I've been so impressed with what our staff have done thus far, but we can get there and make it even better. So it's been a fun project in a lot of ways. It's been stressful as well, but I think it's been so worth it so that we can continue to serve. You mentioned that people have continued to seek treatment with us. I think that will continue to be. Frankly, we're going to see more issues from this coronavirus pandemic with people with their mental health. It's still going to be a big need. So,
agreed. Well, thank you, and thank you for joining us for this fireside chat. We hope you found it informative, and we look forward to your questions.